Welcome to our May installment of Ask the Doctor. My name is Shelly Korean with SkyPass Foundation, and we are here to discuss cell-based genetic and immunotherapies for PD. I'm joined tonight by my lovely co-host, Dr. Shilpa Chitnis, movement disorder specialist who also serves on our board of directors here at SkyPass Foundation. And we are excited to introduce you guys to our special guest for tonight, Dr. Anthony Lang. Dr. Lang is one of the most highly cited investigators in the field of movement disorders, and he will be interviewed tonight by Dr. Chitnis on our chosen topic. So let's learn just a little bit about Dr. Lang before we dive into the discussion. Dr. Lang is professor and previous director of the Division of Neurology at the University of Toronto. He holds the Jack Clark Chair for Parkinson's Disease Research and the Lily Safra Chair in Movement Disorders. He's a director of several PD programs, and his awards and distinctions include the first MDS Pan American Section Leadership Award, the Weston Brain Institute International Outstanding Achievement Award, the Dean's Lifetime Achievement Award for Global Impact from the University of Toronto, and the J. Van Andel Award for Outstanding Achievement in Parkinson's Disease Research. Those are just a few of Dr. Lang's accolades, and we are honored, Dr. Lang, that you are joining us tonight to answer our questions on this very important topic. And speaking of questions, we don't want you guys to hold back. Go ahead and submit those questions live if you're joining us on Zoom using the QA box at the bottom of your screen. If you've got any commentary or insights or experiences that you would like to share outside of questions, you can put those in the chat box and I will be interacting and moderating that. And if you submitted questions with registration, we did receive those and we will be addressing those towards the end of our time together. So with that, I will turn my camera off. I will be back with you guys in a little bit. And Shilpa, I will hand it over to you.
Thank you, Shelley. And thank you, Dr. Lang. It's always a pleasure to have you with us. Let's start with talking about just some basics. To tell our audience, what are cell-based therapies and what is the premise behind their use?
Okay, so thanks for having me this evening. I'm glad to join you, and hopefully we'll be able to fill people in on some important topics. So cell-based therapies are largely therapies that are attempting to replace degenerated nerve cells. So in Parkinson's disease, everyone knows, or most of your audience is aware, that this is a neurodegenerative disease. There is a loss of brain cells due to a degenerative process. And so most of the thinking behind cell-based therapies is that we can somehow replace the lost cells. Many treatments are attempting to slow progression or improve symptoms, but none of these actually attempt to replace the damaged nerve cells. And so cell-based therapies are largely directed at doing that. Now, there are other considerations for cell-based therapies. So for example, some cell-based, we're going to talk about stem cells, and there are a certain kind of stem cell called a mesenchymal stem cell. And that, if it ever becomes useful, probably has more of an anti-inflammatory effect rather than attempts to replace degenerative nerve cells. So most of the time we think of replacing the damaged cells and dead cells.
Thank you. So what is the difference between undifferentiated and differentiated cell-based therapies?
We think of undifferentiated cells as those cells that haven't declared a certain type of cell. So you can imagine you have many, many different types of cells in your brain. And the naive thinking, unfortunately, and the hope that everybody had was with the concept that stem cells would allow us to replace all of the degenerated nerve cells. Independent of what type of nerve cell they were, you just put those stem cells in and they have the capability of replacing all of the lost cells. So again, most of your audience knows that one of the most important cells in the brain to Parkinson's are cells that make dopamine. And with the absence or the loss of dopamine, we have the need to replace dopamine. And So a lot of the cell-based therapies that we're going to talk about are attempting to replace dopamine cells. So they are more differentiated. Those are treatments where you replace cells that are designed to manufacture and release dopamine. But the naive concept, as I was getting at, is that we replace all the different types of cells. So Parkinson's is not just a dopamine cell loss. We have many different types of cells that are lost. And so the naive concept was you use stem cells to replace everything. Unfortunately, that is, as I say, naive. It doesn't work. What we have to do is differentiate the cells and choose specific types of cells to put into the brain. And this is where the emphasis has largely been in attempting to replace the damaged dopamine system.
Absolutely. And you talked a bit about misencephalic cells. And so in the past, what studies have been done with the fetal misencephalic cells, and why did those studies not succeed?
So actually, I've said mesenchymal cells. If I use mesencephalic, I apologize. I may have been confused. But so you've got different types of cells. Let's just get the mesenchymal cells. So there are these stem cells that arise from a certain part of the embryo that mainly is the part that makes things like muscle and other structures. That is not what we think is going to be the useful type of cell that will be applicable in Parkinson's. Let's then use the term mesencephalic. Mesencephalic refers to the midbrain, the part of the brain where the dopamine cells lie. And so in Parkinson's disease, the degeneration is in the midbrain. You lose your dopamine cells as a major but not exclusive degenerative process in Parkinson's. As I said, there are many other kinds of cells that are involved too. But when your midbrain is involved and your dopamine cells are lost, that's when you get the early symptoms of Parkinson's. And so mesencephalic cells came from fetuses. So there was an era where fetuses were harvested. Typically, these are fetuses that were aborted. And so when the fetus was aborted, the fetus was taken and the researchers would dissect the midbrain part of the fetus's brain, recognizing that one of the most important cells in that region were the cells that were going to go on to develop dopamine cells. And so that's what the concept was. They would take these mesencephalic cells from a fetus and implant those cells into a patient with Parkinson's disease. And in fact, there's been a fair amount of experience with that. In some cases, it has been amazingly effective. In the majority of cases, it has been less than what we had hoped. And there are many reasons for that. One, the cells may have not survived. Second, many of the cells that are in the midbrain in the mesencephalon were not cells that were going to become dopamine cells. So there was a very non-specific group of cells that were implanted into the patient's brain. And then there are actually reasons that we don't understand why the patients didn't do well. But a small proportion of patients who had these fetal transplants did extremely well, and in fact came off levodopa and other Parkinson drugs and have done well for quite a long time after the fetal transplant. But unfortunately, that was a small proportion. And then the other thing that we saw with these fetal transplants, these fetal mesencephalic transplants, is that they induced dyskinesia. The abnormal involuntary movements that we know can be induced by levodopa were induced by the transplant. And you didn't need levodopa to maintain the dyskinesia. It was the transplant and the cells in the transplant that were driving the dyskinesia. There are many hypotheses that underlie why that happened, but that was another big problem with the fetal mesencephalic transplants. And so the field has really died down. There are still some researchers that are working on that, but the main interest now is not in using fetal mesencephalic cells, but using stem cells that induce or can be induced to make dopamine cells. And I think that's your next group of
Yes, so
questions.
segue into, with embryonic stem cells, and are there any, promising studies that are now being done?
So there are studies that are taking stem cells from embryos. This whole field has evolved absolutely remarkably. And we now know that using various protocols, using various chemicals and growth factors and inducers, that we can take a stem cell, a cell in the fetal brain that can become any kind of cell. It can be a nerve cell and any type of nerve cell. It can be a supporting cell. There are cells in the brain called glia that support the nerve cells. So all of the brain cells can originate from a stem cell. So what the protocols do is take a stem cell, an embryonic stem cell, and then induce it to become a dopamine cell. Again, we're not using a stem cell and just popping it in the brain and saying, go to it, replace all the cells that are abnormal in the brain. What we're doing is we are inducing the stem cell to become a dopamine cell. And unlike the fetal cells, what we're doing is inducing an infinite number of cells. We have the ability to grow huge numbers of dopamine cells that would originate from the midbrain. And then we can take those dopamine cells and implant them into a brain of a patient with Parkinson's. So that's very hopeful. The problem is that not everything, as I already told you, not everything in Parkinson's disease is dopamine. And one of the biggest problems in Parkinson's is that we have many symptoms that have nothing to do with dopamine deficiency. And in fact, a lot of our best treatments manage the dopamine problems now. So deep brain stimulation, duodenal infusion of levodopa are very good for the dopamine symptoms. Whereas many symptoms like speech difficulties, swallowing problems, cognitive problems, walking problems, instability and falls, many of those symptoms don't relate to dopamine. And so you can put as many dopamine cells into the brain as you want, and you may not be able to address those treatment resistant problems. And that's what we really need better therapy for.
Yes, thank you. So we can switch gears, and this is very useful information, and maybe now talk about genetic therapy. So I seem to lose count. How many genes for Parkinson's disease have been discovered so far?
Well, there are many genes that are involved in Parkinson's. So let's try to differentiate. There are single genetic forms of Parkinson's. Those are called monogenetic forms. Those are rare. So it's really important for the audience to understand that it's extremely rare to have a family with multiple generations, for example, that all have the same gene. We recognize a small number of genes that are capable of doing that. There are only a handful of those. So that's called monogenetic Parkinson's. Now, it's really important to differentiate that from a number of other diseases that are monogenetic, that look like Parkinson's disease, but have many other clinical features that tell us this isn't typical Parkinson's. There are very atypical features. They begin in childhood. They may have a variety of other neurological abnormalities, not the typical features that we see in the older population that has what we think is typical Parkinson's. So those are monogenetic diseases that have Parkinsonism as a manifestation, but not typical Parkinson's disease. Now, what's far more common is the fact that we are complex genetic beings, and we have many genes that then probably contribute to a large number of illnesses. So if you get diabetes or hypertension or hyperlipidemia or a variety of other things that are so common in the general population, you probably get those because of your genetic makeup, in large part, but maybe there are environmental factors as well. What you eat and what you've been exposed to. For example, all the fats and everything might encourage your lipid changes to occur. So there are many genes that also contribute to Parkinson's disease. And in fact, there are now over 90 risk genetic factors in individuals that develop Parkinson's that may contribute. So in fact, we're now talking about a many polygenetic risk score, looking at all these 90 genes that could contribute. And so people with Parkinson's have a higher polygenic risk score than those that don't develop Parkinson's. It may be that that high risk score is still not enough. You may need environmental factors in addition to the risk score that contribute. So to finish then, you've got monogenetic single genes that contribute to or cause Parkinson's or give a big risk. Those are uncommon. And then we have a whole bunch of genes that in combination contribute to your risk of developing Parkinson's.
When you're seeing patients in clinic, how do you make the decision as to for whom are you going to order, genetic testing, and essentially what purpose would that serve?
Good. Okay, so the genetic testing is largely for those monogenetic diseases. We don't do genetic testing for those 90 risk genes that contribute a tiny, tiny amount, but in combination might be important to your risk. So we have a panel of genes that could contribute or could be monogenetic for Parkinson's. Where we will generally use the panel are in those rare individuals who have a very strong family history. Now remember, Parkinson's is a very common disease. It's estimated that 15% of people with Parkinson's have a family history that's positive. Of those, only a small proportion will we find a gene that causes Parkinson's. Maybe only 3 to 5% of everyone with Parkinson's, we might find a gene. And maybe if you had a clear family history, you might only find a gene in 15% of those individuals. So we're still talking about a small proportion. But we will generally do genetic testing in a family history, and it's generally more than just a single cousin or a grandparent. You've got to have a close relative with Parkinson's, and especially if you have more than one close relative. So that would be the first thing, where you've got a higher likelihood of finding a causative gene. Or second, we'll often do the testing in young onset patients, patients who have the disease certainly before the age of 40, maybe up to the age of 50. You clearly have a higher chance of finding a gene causing Parkinson's in someone who develops it under the age of 30 or 40. Now, there is a move in our field to start to consider testing most people with Parkinson's. And I think eventually that's going to happen. So you'll come into the clinic and we're going to do a panel, and that will be a standard approach to evaluating Parkinson's. Now, why would that be? I think it's because we're looking for genetic causes of Parkinson's that might have a specific treatment that applies to the cause. And we'll talk a little bit about that shortly, I imagine.
Yes, thank you. So what are viral vectors and what role do they play in genetic therapy?
Okay, so we're moving now from genes that cause Parkinson's to a different kind of genetic therapy. So in some diseases, like pediatric diseases, one of the goals is to replace a defective gene. And you might do that with what's called a viral vector. So Dr. Chitnis was asking about a viral vector, and we're going to define that in a second. So in some pediatric genetic diseases, the goal is to replace the defective gene. In Parkinson's, so far, that has really not been something that's been applied. It's been considered a little bit, but really it's not something that is currently being aggressively approached. Where genetic therapy is in fact being considered and actually tried experimentally is by using a virus. Now, what do viruses do? They infect cells. So a virus gets into your cell and infects the cell and often changes the DNA in your cell. So what we do is we take viruses, we remove their ability to cause damage to cells, but we retain the ability of that virus to get into a brain cell or into any cell, but in this case, into a brain cell, and to take genes that the virus is attached to and allow the cell that the virus infects to then incorporate the DNA and to start manufacturing the gene that the virus has been attached to. So in Parkinson's disease, what we've done, or what researchers have done, is take a virus like an adeno-associated virus, AAV. They've removed any ability of the AAV virus to damage a nerve cell, but they've retained the ability of the AAV virus to get into a nerve cell, to take whatever's been attached to the AAV virus and to infect the nerve cell with that new DNA. So what's we've attached to viruses are genes that manufacture more dopamine. And so there are 3 different genes that have been attached to different viruses that are then injected into the brain. And those viruses infect the nerve cells, don't damage or don't kill the nerve cell, just infect the nerve cell. And that infection incorporates the DNA of the gene that we're interested in. And that gene then allows more effective manufacture of dopamine. And so that whole idea has been very aggressively pursued with 2 different approaches, 2 different kinds of viral approaches. One was just using something called the enzyme that encourages levodopa to go to dopamine, aromatic acid decarboxylase, AADC. And then, so that was an AAV virus. And then there was another kind of virus called the lentivirus that was combined with 3 different genes that manufacture Parkinson's. You don't need to know the details, but it's tyrosine hydroxylase, AADC, the same as I just mentioned, and another called GTP, cyclohydrolase 1. So 3 different genes.
And so I'm assuming that's the one that was Proseven, right?
These are still being pursued. Yeah, Prosever was the treatment with the 3 different viruses, or the 3 different genes attached to a lentivirus. Unfortunately, the company that developed that, I think, has given up further development. So I think the problem has been that the benefit, so these, important really for the audience to know, these required a neurosurgical procedure. So just like the fetal transplants and the stem cell transplants put cells into the brain, this was a neurosurgical procedure that they had to put these tubes into the brain and infuse or inject the virus that attached to the genes, and that would infect the nerve cells. So it was a neurosurgical procedure. And I think it was generally found that the benefit wasn't what was hoped and probably didn't justify the risk of a neurosurgical procedure.
And similarly with GDNF, with growth factors, right? Where are we going with GDNF at this point?
So one of the thoughts was that we could encourage dopamine cell growth by using what are called growth or trophic factors. There's very little evidence that Parkinson's is associated with a deficiency of these growth factors. So these are normal growth factors that play a very important role, mainly in development. So when the fetus is developing, the growth factors induce growth and sprouting of dopamine cells. And so the thinking was that maybe we could use these growth factors and encourage more growth of dopamine cells in somebody with Parkinson's. And so there was one very, probably the commonest growth factor that's been used in Parkinson's is what's called glial-derived neurotrophic factor, or GDNF. GDNF was used in a variety of different ways. We injected it directly into the ventricular system of the brain. That didn't work. We then put it into the brain substance directly. Unfortunately, that didn't work. Then there was an approach where it was infused repeatedly. This was a very complicated treatment where they had these little ports behind the ears, and the ports were attached to tubes, 3 tubes that went into the brain. And so every month or so, the neurosurgeon would inject the growth substance, the growth factor, into the ports, and this would infuse into the brain. Unfortunately, that didn't work either. There remained a lot of interest in this technique, and there are still people that are pursuing this. The final approach was a gene therapy, taking a viral vector, the same kind of viral vector I just described, with the enzymes, the genes for the enzymes. And what they did was they attached the trophic factor gene. So they put the viral vector into the brain and encouraged the formation of the growth factor into the brain that way. And that was a different growth factor. That was a growth factor called nurturin. And that was injected into 2 different parts of the brain. I was a part of many of these studies, and unfortunately, that didn't work either. One of the problems was that all of the models that were used that looked really positive, and there was very good evidence to go into humans with these treatments. All of the models that were used were animal models where the damage to the nerve cells was with a toxin called MPTP. We now recognize that that's not a very ideal animal model, and it doesn't replicate the degeneration of Parkinson's disease, and that may be the biggest problem. We know that those growth factors were very effective in a monkey, for example, where the toxin damaged the nerve cells, but it certainly wasn't effective in human beings who have a very different kind of disease that causes the degeneration. So it's been a very frustrating history of using growth factors, but there are still some centers and still some researchers that are continuing to pursue other kinds of growth factors. There's a dopamine growth factor that is being pursued by some now.
Yes, it is indeed very frustrating. Just along those lines, what do you think about exercise and exercise inducing these, growth factors, either BDNF or GDNF? So is the induction of the endogenous growth hormones something that's going to prove to be neuroprotective?
I don't know the answer to that. There is a lot of hope and some data to suggest that vigorous aerobic exercise, and this is vigorous and regular, may have a trophic effect on the brain. And you mentioned another growth factor that has been linked to that called BDNF. So there is some evidence that that might be possible. I think the evidence is modest at best. That doesn't mean that exercise is not important. I am a strong believer in exercise. My hope is that exercise may have trophic effects, may induce changes in the brain. Neuroplasticity is a very hot word that everybody loves to use in this respect. If that happens, wonderful. I'd love to believe it and love to think that that's happening. On the other hand, if it doesn't happen, think about the positive impact of exercise on people who have a disease that deprives you of motor function. And if you optimize your motor capabilities by repetitive exercise, You optimize your cardiovascular system through exercise. You diminish your risk of stroke and improve your control of diabetes through exercise. All of those other functions may be as or more important than a trophic effect on the brain or a plasticity effect on the brain. And I think that as a minimum, if we can improve our physical function, our physical capabilities through exercise, and this is not just Parkinson's, older individuals. It's amazing how vigorous exercise. I'm now road biking and I'm healthier than I ever used to be when I was younger. And that has had a very positive impact. And so I think the same applies with the normal aging function, the impact on your joints and your bones, as well as on your brain.
Absolutely, definitely endorse it. Dr. Lang, I forgot to ask you a question. When we were talking about genetic therapies, what about clinical trials on LRRK2 inhibitors or GCase modulators? Do you think those have a good premise?
So now what we're doing is going back to the monogenetic causes of Parkinson's, and the two commonest genes involved in Parkinson's disease are LRRK2 and GBA. And so we know that those genes are very related to and linked to Parkinson's. And so we know that in patients who have a mutation in the LRRK2 gene, there is a component of that gene or a function of that gene called the kinase component of the gene. And the kinase component is overactive in the commonest gene mutations in LRRK2. So there's a lot of interest in inhibiting the kinase function of LRRK2, particularly in people with the mutations. But we now recognize that LRRK2 is important for many, many nerve cell functions that may relate not just to LRRK2 related Parkinson's, but to typical Parkinson's without any LRRK2 mutations. So there's an interest not only in using LRRK2 kinase inhibitors in patients with mutations, but also a very significant interest in exploring the possibility of this same treatment in people with Parkinson's in the absence of the LRRK2 mutation. The same applies to the glucocerebrosidase gene. So we know that people with mutations in that gene are predisposed to Parkinson's disease, but we also know that people with Parkinson's disease have a dysfunction that relates to that genetic function. And so that GBA relates to these little organelles in the nerve cell called the lysosome. And the lysosome is involved in getting rid of garbage, basically. Is one of its function is that it takes abnormal things and it mulches them up and gets rid of them. And so when your lysosome isn't working very well, that's one of the ways the nerve cells have of getting rid of dysfunctional parts to allow them to function more normally. And we know that lysosomal dysfunction is a part of Parkinson's, whether you have a GBA mutation or not. And so there is an interest, just like the LRRK2 story, in patients who have GBA mutations. We definitely want to use drugs that influence GBA function. And so there's similarly an interest in using these same drugs in people who don't have a GBA mutation. And so this whole field is developing very aggressively and rapidly, initially to study patients with mutations of these two genes, but also to apply these same treatments to people who don't have those mutations.
Yeah, and we essentially trying to call these precision therapies very well targeted. So very interesting. So let's talk about immune therapies. And I know you've done a lot of work with immune therapies with alpha-synuclein and participated in a lot of clinical trials. So what can you tell us about where that is going?
Okay, so now we're on to a totally different subject, and that is the use of the immune system to try to treat Parkinson's disease. We know that the immune system is probably very much involved in Parkinson's. Inflammation plays a very important role in Parkinson's and many neurodegenerative diseases. So that's not actually what we're talking about here. We're not talking about the immune system driving Parkinson's. We're now talking about using immune mechanisms to treat Parkinson's disease. And one way of doing that is to think of using antibodies directed at certain proteins. Now, a very important protein in Parkinson's is a protein called alpha-synuclein. We know that if you look under the microscope in a patient with Parkinson's disease who suffered from Parkinson's disease in life, we know that we can define the presence of this protein that's normally there, but it's become abnormal. You can imagine that proteins, look at my hand wiggling along. This is a protein that is unfolded and floating around in the nerve cell. In Parkinson's disease and in other neurodegenerative diseases, certain proteins, and in the case of Parkinson's, the protein is alpha-synuclein, that protein misfolds and it no longer is in solution. It has an abnormal structure. And that abnormal structure is capable of coming into contact with the normal synuclein and inducing misfolding of the normal synuclein that then induces misfolding of the next normal synuclein. So you have an escalating process, a misfolded alpha-synuclein capable of templating and causing misfolding of another synuclein molecule, and this process results in aggregation of this abnormal synuclein, and we believe that that is somehow capable of inducing a toxic gain of function. So that function shouldn't be there. The abnormal misfolded protein now has some sort of toxic effect and is capable of damaging the nerve cells. And this is not unique, as I say, to Parkinson's. We think that this probably applies across the board to most neurodegenerative diseases with different proteins involved in each of them. So if we believe that you've got this abnormal form of alpha-synuclein in Parkinson's brains, the thinking is maybe we can improve patients by trying to change that protein, to try to eliminate the misfolded protein, to try to prevent it from spreading from cell to cell. So you can imagine if you've got a misfolded protein in one cell, one of the processes that we think is important is that that misfolded protein gets transmitted out of the cell to the next cell. So we think that that may be one of the ways that the disease spreads from nerve cell to nerve cell to nerve cell. The misfolded protein has a period of time that it's outside the cell and spreading from cell to cell. So the immune treatments that we're talking about now is taking an antibody. This is called passive immunization. We take an antibody to synuclein and we infuse it into your blood. And this was done monthly. There have been two large trials that have done this with two different types of antibodies. And so every month, patients received an infusion of what's called a monoclonal antibody against alpha-synuclein. The other approach that has been used to a much smaller scale, but there are companies developing it, is what's called active immunization. So passive immunization is you give the antibody. The antibody is already formed, and you give the antibody on a monthly basis and you infuse it. That's not very practical, though, in the long term. So the hope is maybe another treatment would be active immunization, where you get an injection, very much like you get measles, mumps, rubella, and all of the other vaccinations that we've had as children, for example. You get an injection that then encourages your immune system to activate and make antibodies against the synuclein that then would get into the brain and have the same effects as the passive immunization. So that's the immune approach to Parkinson's and many other neurodegenerative diseases. And so there are a number of companies that have developed quite a long list of monoclonal antibodies for passive immunization. And there are a couple of companies that are developing active immunization therapies as well.
Very good. Dr. Lang, can you tell us about the Pasadena trial, which is like the first phase 2 study to look at the efficacy of monoclonal antibody? And are they going into phase 3 now?
So there have been two, as I've mentioned, two large monoclonal antibody studies. One was called the Pasadena study. This was a monoclonal antibody that was developed by a company called Roche and a partner company that was working with them. And then the other monoclonal antibody was a trial called the Spark study, and that was developed by a company called Biogen. And so those two trials, they were very large trials. They involved over 300 patients in each trial. Both of them were, patients were followed for a period of initially a year in what's called a randomized placebo-controlled part of the trial. And then they were followed subsequently where patients who received the placebo then received the active infusion. So that's called an open label extension, where the people that got the active treatment continue on the active treatment. The people that got the placebo now finally get the active treatment after they've received the placebo for about a year. The Pasadena trial that you asked about is the Roche trial. Both of these trials used a rating scale for Parkinson's disease called the MDS-UPDRS. That's the Movement Disorder Society revised version of the Unified Parkinson's Disease Rating Scale, UPDRS. And that evaluates tremor, slowness, stiffness, walking problems. It looks at all of the clinical features of Parkinson's, and it's a composite score. After a year of patients compared to placebo, unfortunately, neither study, the Roche Pasadena or the Biogen Spark study, neither study showed a difference between the UPDRS score in people receiving the active treatments in different doses versus the placebo. That was very unfortunate and very disappointing. In the Pasadena trial, and in all studies, you have what's called a primary outcome variable. You look at the main thing you think is going to give you an answer, and that's the motor component, the movement component, the tremor, slowness, stiffness of that MDS-UPDRS. That showed no difference. But then we look at secondary variables, subcomponents of the scale, a variety of different scores that might give us a signal that we might have missed in the main thing, that primary. So these are secondary outcome variables. And in the Pasadena study, there were a couple of secondary variables that were significant and looked promising. And on the basis of those secondary variables, Roche decided to take the same monoclonal antibody into the next phase, a larger phase 3 trial. Unfortunately, the Biogen study, we looked at both the primary variables and the secondary variables, and none of them showed any significant important differences between the people getting the actual antibody and the people getting the placebo. And so it was finally decided by Roche that they weren't going to develop that treatment any further. Now, there are other companies that are developing other monoclonal antibodies. Unfortunately, we've learned that another company called AbbVie have now given up on the drug or the monoclonal antibody that they were going to develop. They were about to start a trial, and they have now halted that for reasons that were not entirely clear. Maybe it was because those others weren't that effective and they decided it wasn't worth the risk. Maybe they have other reason to stop the development. I just don't know.
Okay, and I think that's end of my questions, Dr. Lang, and I'm going to look at the, thank you so much. I'm going to look at the audience questions. So are there any drugs being tested outside the US that give us hope that there is a cure near term?
I think in practical terms, to be very honest, a cure is not coming in the near term. I think that what we need to do is understand the disease more effectively. And I think that many of us now realize that it's not enough to think of it as a single homogeneous disease. We now need to parcel it out and recognize that there are many factors that contribute to the disease that we recognize as Parkinson's. We've already talked about two very common monogenetic forms, LRRK2 and GBA. I've also told you that there are 90 genetic risk factors. And so your risk score may be very important to the development of Parkinson's. And there are probably a huge number of other factors that play a role. And what we probably need to do is be able to separate out different sub-forms of Parkinson's and say, okay, your combination of these things, your genetics, maybe the presence of abnormalities of the mitochondria, the energy producing components of your cells, maybe the amount of inflammation in your brain, maybe a whole bunch of different factors. Maybe we'll get different abilities to separate out subcomponents and then say, you're a perfect candidate for this drug or this combination of drugs. Whereas if you don't have those combinations, maybe you're a better candidate for another set of treatments. So it might not be appropriate to think of a single cure, particularly about a single disease with a single cure. It may be more likely that we're going to have many different permutations and combinations. Think about cancer. Cancer is a totally different field. You don't have just breast cancer. You have breast cancer with certain receptors. You have breast cancer with certain genes. You have breast cancer that's staged in different ways. And so once the oncologist makes a diagnosis of breast cancer, you need all of these different criteria, and then you receive the treatment that is specific for the type of breast cancer you have. And so I think we're probably looking in the future to seeing Parkinson's evolve in that way.
Somebody asked a very interesting question. What would Dr. Lang do if he had Parkinson's?
What would Dr. Lang do? Well, Dr. Lang would live in a very healthy way. Dr. Lang would exercise vigorously. Dr. Lang would treat his symptoms appropriately as his symptoms are interfering with his quality of life. And that's very important because we have to recognize that we've got very good symptomatic treatment right now. Levodopa is the best treatment we have, and there's still people that are afraid of it. And I see people whose lives, the quality of their life is miserable. They don't recognize that it's quite so miserable because they adamantly believe that they don't want levodopa. They're afraid of the dyskinesia or whatever that might be the reason that they don't want to take it. When they are afraid of dyskinesia, in part maybe they've seen Michael J. Fox on television. I always tell them, what's Michael J. Fox doing? How many years after he was diagnosed with Parkinson's? He's still acting, writing books, producing, and living vigorously. And many of the problems he's got relate to other things that you'll read about in his books, his spinal cord injury, etc. So I think it's really important to recognize that we've got very good symptomatic therapy. And if I felt my quality of life was impacted, and that quality of life may mean many things to many people. I always tell patients that if you retired and you wanted to play golf and loved golf, and now your handicap is deteriorated because of your Parkinson's, I'll treat your golf game because that's important to you. That's your quality of life. So everybody is very individual. And if my quality of life is impaired, I know that I can improve that by taking the treatments that we have now. I would not take CoQ10. There's no evidence for that. I would not take glutathione. There is no evidence for that. I would not spend all sorts of time Googling and following people that don't have good evidence for what they claim. So I think I would follow people that know what they're talking about, that do this for a living. I would be managed by a good doctor that gets to know me for who I am and likes me and has a good personal relationship with me. And that doesn't have to be a movement disorders neurologist, but it's nice if it is. There aren't enough movement disorders neurologists to go around in the world to manage Parkinson's, though. And so that's basically my answer. And I would keep my eye on developments. I'd participate in research. That's really very important. Patients with Parkinson's need to recognize the importance of them being a part of our team. And without a team, without the doctors, the nurses, the patients participating to try to work towards a common goal of understanding the condition or conditions that are Parkinson's and try to get the answers that we need to find those cures. And it may not be a single cure, it may be many treatments. Without that combination, without that team approach, we're never going to get there. So participate in research.
Absolutely. A patient wants to know, I'm currently using Apokin injections for freezing. Would these therapies potentially take the place of this?
So there are many different dopaminergic therapies, and apomorphine is a very potent, good dopamine replacement therapy. It's mainly used for short duration action. So in Europe, apomorphine can be used as a pump, like duodopa. Many of the listeners will know about levodopa, carbidopa intestinal gel. That's a pump that infuses levodopa over a chronic period. Apomorphine in Europe can be used in the same way. Generally, it's not available in North America in that way. It's available for injections or under the tongue in a sublingual form. And that can be very effective if you go into an off state quickly, if you have to wait a long time for your next levodopa to kick in and provide you benefit. Your listener mentioned freezing. It's effective when the freezing is responsive to dopamine therapy. So some people will freeze a great deal when they go off. Other people will freeze at any time of the day unrelated to the level of their dopamine. And that can be very challenging. And in some cases, more dopamine will actually worsen the freezing in some patients. That's uncommon, but we do see it. So when the freezing comes out in an off state, when your levodopa wears off, the apomorphine injections and sublingual apomorphine can be quite effective in getting people on quickly and relieving that symptom.
Glenn wants to know, can you treat my guitar playing?
Can you treat?
My guitar playing, like you said, I could treat a golf game.
My guitar playing. Well, we can treat guitar playing as it is impaired more in the off state and as levodopa may improve dexterity. Unfortunately, this miracle drug replacing dopamine doesn't normalize motor function completely. And so there are symptoms that persist. And sometimes really fine dexterity, especially if you're a great guitarist, it may not get you back to what you were used to before. If you're an amateur guitarist like I am, I might be able to improve. Maybe I'll get better than I was even before I took levodopa, but I think that's pretty unlikely. So if you're looking to normalize a supernormal function, if you're a professional guitarist, maybe it wouldn't get you back to that level. But if you're an amateur person that plays for fun, it probably would definitely help.
Yeah. And the fine motor functions, sometimes, Dr. Lang, are not very easy to come back once they're lost, aren't they?
Yeah, that's very true.
Do you know anything about how high doses of B1, vitamin B1 could affect PD?
B1.
Not
B6. Really.
Yeah.
There's a lot of interest in B6 and B12 as it applies to the impact of levodopa. especially with the duodenal infusions of levodopa, there is some evidence that patients may become deficient of those vitamins. So it's important to monitor those vitamin levels and to make sure that people are adequately replaced. There's no reason to think that supernormal levels of vitamins are appropriate, though. We don't use high doses of any of the B vitamins. I think there's probably good reason to use a B complex on a routine basis to make sure that you're not deficient of B vitamins. Certainly, I recommend that all my patients take vitamin D. I think 1,000 international units of vitamin D is a good thing for many reasons, not just Parkinson's. But you need to recognize that Parkinson's, you may get outside less and get less sun. Your bones get thinner because you're not laying down bone properly. And so vitamin D can be very good for you. But high doses B1, there's really no evidence that it should be used.
Would it be helpful to donate one's body for Parkinson's research?
Yes, I think that we encourage patients to donate certainly their brain, because postmortem studies of people who suffered from neurodegenerative diseases of any sort can advance the research substantially. And so we always talk to our patients about the importance of brain donation. We joke with our patients. I think you need to look at it in a semi-humorous fashion. This shouldn't be a serious discussion. You can't take your brain with you. It goes to mush pretty quickly once you die. The worms get into it pretty fast. It may as well be of some use to future generations. And so using brains to advance science is very important. And I always tell patients, I'm not going to take it before you finish using it. And I'm going to continue to treat and support you as long as you want to keep it. But when you're finished using it, let us take it and help others that suffer from these diseases. Now, there might be a role of donating more than just your brain. So spinal cord and skin and a variety of other tissues may advance the science as well.
Absolutely. Patricia wants to know, I have a great grandfather and a father.
But the brain is the most important, but not exclusively.
Yes.
Say again?
Yeah. So Patricia wants to know, I have a great grandfather and a father who had Parkinson's. Would I be a candidate for genetic testing?
Yes, I think that's reasonable. If you've got more than one generation, a father, a grandfather, a great-grandfather, it's still, we see a lot of patients with even a stronger family history than that, where we don't find the genes. That just simply tells us that a genetic factor is probably there. Maybe that combination of the polygenic risk score is strong in that family, and there's still other factors that we don't understand. But I think if you've got 3 generations affected by Parkinson's, there is a chance we'll find a monogenetic gene like LRRK2, for example, and then you might be a candidate for one of the developing experimental therapies that is designed specifically for that type of Parkinson's.
Shelley, I think we're at 8 o'clock. Time to wrap up.
Yes,
I'll let you take over.
Let's just get a couple more quick questions in here. We had a few questions, Dr. Lang, that came in from folks that have DBS. So I'm going to try to consolidate all of those into one question. I think the main question here is, do any of the therapies that were discussed tonight, are they recommended or not recommended for people with DBS? Why or why not?
So pretty well all of the treatments that we've talked about tonight are still experimental. So we've talked about gene therapies. We've talked about gene-based therapies, LRRK2, GBA. We've talked about trophic factors, et cetera, and cell-based therapies. These are all experimental. I think that if you are at a center where there are experimental therapies going on, you will probably find that at least in the earliest stages, when they're developing these therapies, there are groups of patients that are excluded. And one group that is most often excluded with Parkinson's are people who have already undergone deep brain stimulation. that doesn't mean that if the treatment develops and is shown to be effective, you couldn't benefit from it. It just means that you probably couldn't participate in the experimental phase of the trial, because there are some rigorous inclusion and exclusion criteria. But it might be they'll be useful to you in the future.
Got it. One last question. One of our attendees says, I'm 74, male, been diagnosed for 7 years, physically getting worse the last 2. I'm physically active, exercising as often I feel up to it, had a couple of episodes of hallucinations. Is it too late for me to benefit, or would it be too late for anyone to benefit from gene therapy or stem cell therapy at that age and stage of Parkinson's?
We don't know the answer to that. I think the challenge is that we need to see that they're effective. Remember, they're all experimental. Stem cell therapies are not being widely applied. There are a small number of companies that are developing dopamine-related stem cells, so dopamine cells that have come from stem cells. In the future, if we find that these are safe, number one, really, really important, and effective, obviously equally important, if we find that these are safe and effective, then maybe in the future, people who've had disease for a long period of time could benefit from that. But we're unfortunately a ways away from answering that question. We need to show safety and efficacy, and they are just starting. There's one study that's being done in North America now that is just getting started. So we're a long ways away from that, unfortunately.
Got it. Okay, I think we got most of our questions answered. Thank you, Dr. Chitnis, for the interview. And thank you so much, Dr. Lang, for joining us tonight and for sharing your knowledge with us. And thank you everyone for attending. For those who are joining us live, thank you for being here. This is being recorded and we will be sending out a link to the recording. So if you would like to watch this again or send it to someone that you think can benefit from that, please do so. And last but not least, Chillin' with Chitnis is back on for next month. Registration is open. Dr. Chitnis will be addressing some topics related to living well with Parkinson's. We've got some questions that we've received regarding social interactions, employment issues, as well as some other practical issues that people with Parkinson's deal with on a daily basis. So as a reminder, you don't have to wait till your next appointment with your movement disorder specialist to get those questions answered. Join us next month and register at SkyPassFoundation.org. And as always, we're here to answer any questions or address any concerns that you guys may have. So with that, we will wrap it up. Thank you again so much, Dr. Lang, for your time. We hope to have you back with us again soon. And thanks, Dr. Chitnis. Have a great night, everyone. Take care.
Good night, everybody. Bye-bye.